Welcome back to Endo in a Bite, the podcast where the 2025 Thyroid Cancer Management Guidelines are broken down into simple, clear lessons you can actually remember. Today we are covering recommendations 57 through 72. This section focuses on radioactive iodine use, refractory disease, targeted therapies, and when to introduce systemic treatment. Let's begin. First, bone metastases. Radioactive iodine improves survival in patients with bone metastases that still absorb iodine, and it should be used in this setting. The dose can be given as a standard range of 100 to 200 millicuries, or it can be determined more precisely by using dosimetry. Next, patients with elevated thyroglobulin but no visible disease. If there is no structural disease and the stimulated thyroglobulin remains low, these patients can be safely followed on thyroid hormone alone. Radioactive iodine is reserved for those with significantly elevated or rising thyroglobulin when imaging cannot find treatable tumors. If empiric radioactive iodine is given and a response is seen, additional treatments can be considered until the disease no longer responds. Now, the definition of radioactive iodine refractory disease. This diagnosis cannot be made unless the patient has actually received radioactive iodine. Once it is confirmed that the disease is refractory, additional empiric radioactive iodine should not be given, and other treatments must be considered. How do we monitor refractory disease? If the disease is stable, asymptomatic, or only minimally progressive, these patients can often be followed on thyroid hormone suppression with imaging every 3 to 12 months. Molecular testing is not recommended unless systemic treatment or an attempt at redifferentiation is being planned. Before starting systemic therapy, tissue should be tested for actionable oncogenic driver alterations. This biomarker testing is essential. When systemic therapy is needed and there is no actionable biomarker, the first-line option is a multikinase inhibitor. The drugs are lenvatinib or sorafenib, with lenvatinib preferred. When should lenvatinib be started? If the patient is symptomatic and not a candidate for local therapy, treatment should begin right away. For patients without symptoms, the timing depends on goals. If maximizing treatment effectiveness is the top priority, earlier initiation should be considered. If maintaining quality of life is most important, delaying treatment and continuing to monitor may be best. The usual starting dose of lenvatinib is 24 milligrams daily, although some patients may need a lower dose. Dose interruptions and reductions are important tools for managing side effects. Managing side effects is critical to success with these therapies. Patients should be assessed at baseline, then every 2 weeks for the first 2 months, and then every 1 to 2 months after that. If a patient progresses after or cannot tolerate first-line multikinase inhibitors, the second-line treatment is cabozantinib. Now, targeted therapies. If a tumor carries a specific gene alteration, treatment should match that target. If there is an oncogenic NTRK fusion, NTRK targeted therapy is recommended in the first line. If there is a RET fusion, RET-targeted therapy is recommended in the first line. For anaplastic lymphoma kinase fusions, use an anaplastic lymphoma kinase inhibitor. In patients with progressive radioactive iodine refractory differentiated thyroid cancer who carry a BRAF V600E mutation, therapy directed at BRAF V600E may be considered as first line. In those who are not good candidates for lenvatinib. For patients with BRAF V600E positive radioactive iodine refractory disease who have already progressed on or could not tolerate one or more multikinase inhibitor treatments, BRAF-directed therapy is recommended. It's also important to note that the currently approved BRAF-directed treatments are not recommended for thyroid cancers that carry non-V600 BRAF alterations. If another actionable mutation is identified, patients should be referred to a clinical trial, if available, or managed with lenvatinib. And finally, whenever possible, obtain a surgical or core biopsy for next-generation sequencing to uncover resistance mechanisms. If biopsy is not feasible, circulating tumor DNA may be considered as an alternative. So let's recap. Radioactive iodine is effective for iodine-absorbing bone metastases. Rising thyroglobulin without visible disease may justify empiric radioactive iodine. Once disease is refractory, no further radioactive iodine should be given. Stable or minimally progressive refractory disease can often be monitored. Biomarker testing is essential before systemic therapy. Lenvatinib is the first-line drug, and cabozantinib is the second line. Targeted therapies should be used when specific gene alterations are present, and biopsy helps uncover resistance mechanisms when patients progress. That concludes recommendations 57 through 72. This was another bite-sized episode of Endo in a Bite. If something went by too quickly, do not worry. I have prepared notes for you. Visit easyendoprep.com to sign up for the newsletter, and the key pearls will be delivered straight to your inbox. Remember, stay consistent, and together we will work through all 84 recommendations, one bite at a time.